everyone, thank you for joining me. Today we'll be going over depression in geriatric population. Depression can be seen in 5% of general community, 13.5% of home care facilities, and 11.5% in patients that are hospitalized. Some symptoms that can cause depression can be major depressive disorder. This can be if happened before 60 or after 60 years old. Minor depressive disorder, mixed anxiety depressive disorder, dysthymic disorder, bereavement, and adjustment disorder with depressed mood. Some causes of depression can be medical conditions such as cancer or chronic pain, vascular depression, substance-induced depression, medication-induced depression, and depression executive dysfunction syndrome. Some of the risk factors that can cause depression can be medical condition, functional limitation, stress, whether it's stress of life or caregiver, sleep problem, social isolation, genetics, and lack of exercise or physical activity. Some medications that can cause symptoms of depression can be beta blockers, steroids, opioids and benzodiazepines, Parkinson's medications, H2RA, and clonidine and hydralazine. Some medical conditions that can induce symptoms of depression can be dementia or sensory loss, cerebrovascular or cardiovascular disease such as stroke or MI, cancer and chronic pain, vitamin deficiency, anemia, infections, and anxiety. Some symptoms of depression that can be seen is sad or empty mood, feeling of hopelessness, restlessness or irritability, loss of interest in pleasurable activities, decreased energy, fatigue, moving slowly or talking slowly, difficulty sleeping or oversleeping, loss of appetite, and eating more. The diagnostic tools that is used can be Geriatric Depression Scale, GDS, Cornell Scale of Depression in Dementia, Patient Health Questionnaire, DSM-4, Hamilton Rating Scale for Depression, and Suicide Risk Assessment. When choosing a treatment option for this patient population, it is important to keep in mind their comorbidities, their renal and hepatic function, and if they have used any previous medications. Treatment options available are psychotherapy or counseling, which is used as first line or as adjunct. Medications such as our SSRI, including citalopram, escitalopram, or sertraline. SNRI, such as venlafaxine, duloxetine, desvenlafaxine. It is important to keep in mind that venlafaxine has high risk of blood pressure, elevating blood pressure. Our NASSA, mirtazapine. Low doses may cause sedation and appetite stimulation, but use cautious when using this medication in cardiac disease patients. Our NRA, bupropion. It is mostly used in patients that their depression is associated with lack of motivation, and it is contraindicated in patients with history of seizures. Our last line of therapy are TSA agents, not used as first line because they are highly anticholinergic. The second generation antipsychotics such as aripiprazole and risperidone, and lithium. It is important to keep in mind that these medication needs to be started low and go slow. Beer's list criteria mentions that our antipsychotics such as mirtazapine, SNRI, SSRI, and TSA to be used with cautions because they can cause or exacerbate SIADH and hypernatremia. The antidepressants such as our TSA agents and paroxetines are highly anticholinergic and to be avoided. Antidepressants with use of antipsychotics, anti-epileptic, and benzodiazepine or Z drugs, more than 3 of these drugs may increase risk of fall or fracture. Lithium toxicity can be increased if it is used with ACE inhibitor or loop diuretic. We as pharmacists can help by asking if they have been feeling down, depressed, or hopeless, or if they have been having little interest or pleasure in activities, and conducting a full medication history. Some ways that we can help this patient to prevent depression is help them to stay active, eat healthy, make sure that they are getting enough sleep, and they are participating and staying in touch with the community and their loved ones. That is the end. Thank you guys for listening.